Okay, let us continue from question number 8. A 53-year-old woman comes to the office due to itching pain in her legs. She is a hairstylist and has cut down on her work hours due to the discomfort. The patient is a history of migraine and untreated chronic hep C. She smokes a pack of cigarettes daily but doesn't use alcohol or recreational drugs. Physical examination findings are shown in the image below. An abnormality affecting which of the following is most likely cause of this patient's symptoms. So pause it and give the answer. So this is the case of varicose veins. Why? Because she is a hairstylist and would stand over there for a long time. That would cause varicose vein, right? Abnormality in the veins, venous walls, right? Okay. So venous walls problem that is associated with pregnancy might be associated with obesity and deep venous thrombosis and prolonged standing and sedentary lifestyle. What about option A, arterial edema? That can predispose to peripheral arterial disease, presents with pain in exercise, will present with claudication, and if severe, pain at rest with possible distal gangrene. Capillary permeability, uh, that is usually affected in anaphylaxis, other allergic reactions, inflammation, and shock. That would cause edema if capillary permeability is increased, right? And this is not associated with varicose veins. Lymphoid capillaries. Obstruction of lymphoid capillaries produces lymphedema, right? There will be marked swelling of distal lymph. Initially, that would be soft plus pitting edema, right? Initially, that would be soft and pitting, right? But then finally will become firm and non-pitting type. We will look that we will watch that figure, right? You will understand this. Okay, then plasma oncotic pressure, that would causes generalized edema, right? And this is usually associated with nephrotic syndrome, cirrhosis, or liver failure, right? Cirrhosis with portal hypertension, what would that cause? That would cause esophageal and anorectal varices, right? But not lower extremity varicose veins, right? Because the portal hypertension is not associated with lower extremities, right? So that's why that is not. But here, this is the case of lower extremity problem, right? Okay. Why not vasa vasorum? The narrowing of the arterioles of vasa vasorum, that is associated with aneurysm formation, right? But not varicose veins. Okay. This is the patient with varicose veins. Okay, that will be presented with hyperpigmented skin, varicose veins. These are super dilated superficial veins, right? Which are due to chronically elevated venous pressure. Okay, and due to hemosiderin, there will be deposition. The skin hyperpigmentation is due to hemosiderin accumulation in the dermis, right? Okay, so dilated superficial veins, varicose veins, associated skin changes, and status that is consistent with stasis dermatitis. Venous blood normally flows from superficial veins to perforating veins into the deep veins of the extremities. Blood from the deep veins then travels upward and eventually drains into the inferior vena cava. Walls located in these vessels prevent backward flow from deep to superficial veins. This is important. Varicose veins are varicose veins and incompetence of the walls that would cause venous stasis dermatitis associated with poor wound poor wound healing, right? Risk factors for varicose veins and stasis dermatitis include obstruction of venous return, for example, in obesity, pregnancy, conditions that damage the venous walls, deep vein thrombosis. We talked about this. Prolonged standing and sedentary lifestyles are also associated with varicose, but that are not that much common. Okay, atherosclerotic changes of the arterial edema. We talked about this. Okay, ischemic capillary permeability is associated with anaphylaxis. We talked about this. Doesn't play a role in the development of varicose veins, right? This is important. Okay, why not option C? That will produce lymph edema. We talked about this thing. We talked about these things, right? Initially soft in pitting. We talked about this. Okay, then option D, decreased plasma and cortic pressure. We talked about this. That will happen in nephrotic syndrome, cirrhosis, or liver failure. That would present with generalized edema, right? Okay, lower extremities do not communicate with portal hypertension. I mentioned this reason. Okay. Okay, so educational objective is chronically elevated venous pressure in the lower extremities can lead to incompetent venous walls, venous dilation, that is varicose veins, venous congestion, and tissue ischemia, venous stasis dermatitis. Right? Okay. So, what is the pathogenesis? Dysfunctional wall, retrograde blood flow. Right? And dilated tortuous vein, varicose vein. Normally, the walls are competent. Okay, this is the lymph edema, and it is in the later stage. In the later stage, you know, markedly swollen extremity with thickened skin. Okay, initially it was pitting, but when it grows in the later stage, it will become non-pitting and thick, soft. First, initially it was soft, right? It will be soft, but then it will become hard. Okay, now in question number 9, the following vaginate applies to the next two items. The items in the set must be answered in sequential order. Once you click proceed to next item, you will not be able to add or change an answer. Okay. A 67-year-old man comes to the emergency department due to progressive shortness of breath and chest tightness. He has had no light headedness or syncope. The patient takes lisinopril for HTN and metformin for type 2 diabetes mellitus. Okay. Smokes a pack of cigarettes daily for the last 40 years. The BP cuff is inflated to 140 mm of Hg and the pressure is released very slowly. At 120 mm of Hg, intermittent cough sounds are heard only during expiration. At 100 mm of Hg, cough sounds are heard throughout the respiratory cycle. Item 1 of 2. This physical examination finding can be seen in which of the following conditions? Please select any one of these. Pause it and then give the answer. Okay, so the correct answer in this case is pericardial disease. Right, it is not the peripheral vascular disease. It's just for your confusion, right? Okay, so the item 2 of 2 is the patient is tachycardic and unable to speak in full sentences. Examination reveals prolonged expiration and prominent bilateral wheezing. Heart sounds are normal, right? Chest imaging shows normal sized heart, hyperinflated lungs with a flattened diaphragm. Bedside echocardiogram reveals no intrapericardial fluid accumulation or pericardial thickening. Which of the following physiologic changes is most likely to provide immediate relief in this patient? Cyclic AMP accumulation in smooth muscle cells. Option B, cell membrane stabilization of mast cells. Option C, inhibition of eosinophil degranulation. Option D, interrupted histamine receptor firing in epithelial cells. Option E, opening of calcium channels in smooth muscle cells. Pause it and give the answer. So the correct answer over here is cyclic AMP accumulation in smooth muscle cells. Right? Okay, let us see the explanation. So the first thing is whenever the difference between whenever during inspiration and expiration, here the difference between these two is greater than 10. If it is greater than 10, then that will lead to pulsus paradoxus, right? What is the definition of pulsus paradoxus? This is important. Pulsus paradoxus refers to an exaggerated drop that is greater than 10 mmHg in systolic BP during inspiration, right? If the if the drop is greater than 10 during inspiration, then that would be pulsus paradoxus. Over here it is the difference of 20, right? So fall in systolic BP is greater than 10 mmHg, that is pulsus paradoxus. Pulsus paradoxus. Okay. In aortic wall stenosis, so here option D is the correct, right? Pulsus paradoxus is the condition which is associated with the pericardial disease, right? What about pulsus paradoxus? They are saying most commonly seen with cardiac tamponade. This is important. But can also be seen with severe asthma, COPD, and constrictive pericarditis, right? This is in option in second item that is associated with severe asthma, so that can be also presented with the pulsus paradoxus, right? So pulsus paradoxus is most commonly seen with cardiac tamponade, but can also be seen with severe asthma, COPD, and constrictive pericarditis. Why not other options? Let us go through all. Option A, aortic wall disease. That in that case, a fixed left ventricular outflow obstruction, like valvular aortic stenosis, that will produce pulsus parvus et tardus. Pulsus parvus et tardus, right? That would be slow rising, low amplitude pulse due to decreased stroke volume, that is called pulsus paradoxus, and prolonged left ventricular ejection time, that is called pulsus tardus. So in valvular aortic stenosis, pulsus parvus et tardus, right? That is associated with that. Okay. Slow rising, low amplitude pulse due to decreased stroke volume, that is pulsus parvus, and prolonged left ventricular ejection time, that is pulsus tardus, right? Mitral regurgitation, that is associated with bounding pulse, right? Over here this is pulsus paradoxus, that is associated with pericardial disease, but in mitral regurgitation that will produce bounding pulse with that upstroke brisk, right? Due to uh, left ventricular increase in left ventricular ejection, due to increase in left ventricular ejection volume, right? Because the fluid will go in the backward direction, right? In mitral stenosis, arterial pulse reduced due to decreased stroke volume, right? MI, that causes decrease in systolic BP, okay, or hypotension. due to decrease in cardiac output. That is not associated with pulsus paradoxus. Right? Okay, why not option E? Because peripheral vascular disease would decrease pulse amplitude in affected extremities. Right? This is most commonly seen in lower extremities, peripheral vascular disease, present with diminished or absent distal pulses. Right? Okay. So we talked about this. Let us move quickly through this. Systemic arterial pressure normally falls by less than 10 mmHg during normal inspiration. That is, in case of pulsus paradoxus, exaggerated drop greater than 10 mmHg in systolic BP during inspiration. We talked about this. Detected by inflating a BP curve above systolic BP and gradually deflating it. The difference between the systolic pressure at which Korotkov sounds first become audible during expiration and the presence at which they are heard throughout all phases of respiration quantifies pulsus paradoxus 20 mmHg as in this patient. We talked about this case. Inspiration causes an increase in systemic venous return, increase right heart volumes. Under normal conditions, this results in expansion of the right ventricle into the pericardial space with lateral effect on the left of the heart. In conditions that impair expansion into the pericardial space, acute cardiac tamponade, the increased right ventricular volume occurring with inspiration leads to bowing of the interventricular septum toward left ventricle. A decrease in the left ventricular end diastolic volume and stroke volume, a resultant decrease in systolic pressure during inspiration. We talked about this. Okay, why not option A? We talked about this fixed left ventricular outflow tract obstruction, valvular aortic stenosis. That would cause pulsus parvus et tardus. We talked about this. Chronic severe mitral regurgitation that would produce bounding pulse with stroke. Increased left ventricular ejection volumes. Okay, we talk about MI that is not associated with pulsus paradoxus. Peripheral vascular disease. We talked about this. That will decrease pulse amplitude within affected extremities, not overall. Right? Okay. Pulsus paradoxus is defined as by a decrease in systolic BP of greater than 10 mmHg with inspiration, most commonly seen in patients with cardiac tamponade, can also occur in severe asthma, chronic COPD, uh, chronic obstructive pulmonary disease, okay, and constrictive pericarditis. So this is pulsus paradoxus. The difference is more than 10 mmHg. Over here it is 20, right? Okay. During the respiratory cycle, the drop in systolic BP during inspiration. Over here we can see the guys, let's say it is inspiring, so the volume is increased, but the pulse pressure difference over here, if you see, the difference is greater than 10, it is 20. Okay, so that's why during inspiration, if it is greater than 10, that will be pulsus paradoxus. Right? Okay. Okay. Item 2 of 2, we have prolonged expiration, bilateral wheezing, hyperinflated lungs. Right? Heart sounds are normal, so it is not the case related to heart problems. The sound, because sounds are normal, so no mitral regurgitation or aortic stenosis, because those are producing some type of heart sounds like diastolic murmur sounds, systolic heart sounds, okay, just like that. Normal size heart, so no hypertrophy, hyperinflated lungs, right? And no intrapericardial fluid accumulation or pericardial thickening, okay. Okay, now this is the case of COPD or asthma. Now they're saying most likely to provide immediate relief, right? So for immediate relief, what we give to the patient is beta adrenergic drugs, right? like albuterol, salbutamol, just like that. Okay, which are used for acute exacerbations, right? What they do is they will activate innyl cyclase that will increase intracellular cyclic AMP. Why not option B? Cell membrane stabilization of mast cells. Cromolyn sodium used for management of chronic asthma, not acute exacerbation. This is important. That what is the mechanism of that? Inhibit release of histamine and leukotrienes. Okay, why not option C? Inhibition of eosinophil degranulation. That is important. Corticosteroids used for acute exacerbation of asthma and COPD, but will take few hours to days. This is important. While beta agonists show immediate relief. Now, why not option D? Interrupted histamine receptor firing in epithelial cells. These are antihistamines, right? They are not effective for asthma and COPD exacerbations. Opening of calcium channels in smooth muscle cells. So these are calcium channel agonists that would worsen bronchial smooth muscle contraction, right? So they are contraindicated in asthma and COPD patients, right? Okay. So dyspnea, tachypnea, prolonged expiration, bilateral wheezing, suggestive of acute exacerbations of obstructive pulmonary disease, asthma, or COPD. Acute obstructive pulmonary exacerbations are primarily treated with beta adrenergic agonists, produce relaxation of bronchial smooth muscle by stimulating the beta 2 adrenergic receptor. G stimulatory protein coupled receptor activates adenylyl cyclase, increases intracellular cyclic AMP. We talked about this. Asthma and COPD exacerbation most frequently causes of pulsus paradoxus in the absence of significant pericardial disease, pericardial effusion, or constrictive pericarditis. There is a small normal variation in intrathoracic pressure with respiration, which drops 2 to 5 mm of Eg below the atmospheric pressure during inspiration. Okay, now this is in patient with severe asthma or COPD exacerbation. This drop in intrathoracic pressure becomes greatly exaggerated and is transmitted to extrathoracic structures. Excessive drop in BP with inspiration, that is known as pulsus paradoxus. Right. Okay. We talked about cromolyn sodium management of chronic asthma. Okay. Eosinophil degranulation, corticosteroids. We talked about this. Okay, corticosteroids would take several hours to few days to take effect. This is important. Antihistamine therapy not effective for asthma and COPD exacerbation. This is important. Okay. Then we talked about calcium channel agonists that would calcium influx would worsen because they are increasing contractility, right? Okay. So asthma and COPD exacerbation most frequent causes of pulsus paradoxus in the absence of significant pericardial disease, beta adrenergic agonists, acute asthma and COPD exacerbations, bronchial smooth muscle relaxation via increased intracellular cyclic AMP. Okay, good. Now let us talk about on the next question. 75-year-old man, okay, is brought to the emergency department after family uh, his family found him to be lethargic and confused. Okay, the patient has a history of hypertension, coronary artery disease, heart failure. Temperature is 35 degrees centigrade. BP is 78 by 46 mm of mercury. Pulse is 110 per minute. The patient is admitted to the intensive care unit and a pulmonary artery catheter is placed, which demonstrates the following readings: cardiac output high, central venous pressure low, pulmonary capillary wedge pressure low, mixed venous oxygen saturation high, systemic vascular resistance low. Most likely cause of this patient hypertension is option A bacterial infection, option B GI bleeding, option C heart failure, option D hypothermia, option E myocardial infarction, option F pulmonary embolism. Pause it and give the answer. So the correct answer for this question is bacterial infection. Bacterial infection is associated with septic shock, right? Which is the type of distributive shock. Okay, so yeah, okay. So we talked about this that would cause septic shock, bacterial infection, distributive shock, right? That would decrease distributive. What happened in distributive shock is it will cause vasodilation, right? It will cause vasodilation. So the systemic vascular resistance, right, or TPR, total peripheral resistance, that would be decreased, right? Now if there is vasodilation, right, what will happen due to which, due to that, what will happen is the central venous pressure and pulmonary capillary wedge pressure would be decreased. What is central venous pressure? Central venous pressure is the pressure in the right atrium. What is pulmonary capillary wedge pressure? Pulmonary capillary wedge pressure is the pressure in the left atrium. Right, let me draw this for you guys. Okay, let's say this is the case of heart, right? Okay. Now if vessels are vasodilated, right, so there will be less blood flow to here, right? You know how the venous return is increased whenever there is vasoconstriction. If these vessels are constricted, then the fluid return will be increased, due to which the pressure will be increased, right? Over here, that will be called a central venous pressure, CVP, right? And whenever this is high, we know that uh, venous return venous return is the same as cardiac output, right? Cardiac output is on the let's say on the left ventricle. Okay, so if this is the same as this, this will be also raised. Over here the pressure, if venous return is high, right, that fluid will come first first from right atrium to the right ventricle, then to the lungs, then to the left atrium, right? So here the pressure will be raised. So pulmonary capillary wedge pressure will also be raised, right? Okay, so okay, so the pulmonary capillary wedge pressure would be increased. What will happen is a compensatory mechanism, right? There will be increase in heart rate and contractility. Now if there is increase in heart rate and contractility, we know that cardiac output is dependent on these things, right? So so what will happen, there will be increase in cardiac output, right? Now if there is increase in cardiac output, remember in this distributive shock there is increase in cardiac output, while in other there will be decrease in cardiac output, right? There will be decrease in cardiac output. This is important, remember this for MCQ. So let's say if there is increase in cardiac output, so there will be less time. Let's say if these are arterioles, right, and if these are venules, right, and these are capillaries, what what we know is there is exchange of blood, gaseous exchange in the capillaries, in the tissue, right? So if the cardiac output is high, so there will be less time for this blood flow to move from arterioles towards venules, right? So what will happen, there will be less chance for oxygen to exchange with those tissues, right, with those cells. So due to which the maximum oxygen, mixed venous oxygen concentration would be increased, right? So the oxygen will be not uh, fully uh, exchanged with the tissues, that will be moved toward the venous side. Okay, so that's why we say that the um, mixed venous oxygen saturation would be increased, right? While in the other cases, in the other shock, we will see that would be decreased, right? But over here it is increased. This is important. Okay, in GI bleeding is since the volume is decreasing, right? The blood volume is decreasing. That is associated with hypovolemic shock, right? Now, due to which, what will happen if the volume is low, then the venous return will be low, right? Because venous return depends on the volume, right? On the blood volume, right? Fluid. Okay. We say, for example, we say if we want to increase the venous pressure, the venous return, what we will do, we can do IV fluid. We can uh, and with that we can do what we can do blood transfusion, right? We can do blood transfusion that will increase venous return, right? So here in this case, the venous return will be low, right? Because the volume has decreased due to bleeding. Okay, due to which there will be low central venous pressure, right? Due to which also pulmonary capillary wedge pressure will be decreased and cardiac output would be decreased. Is a compensate, as I mentioned, in all the other cases, in all the other cases of shock, except distributive shock, where the cardiac output was increased, the cardiac output would be decreased. The cardiac output would be decreased in all the cases. This is important. Now, is a compensatory mechanism. What will happen? What will happen is that there will be increase in SVR. Peripheral vascular resistance would be increased. Systemic vascular resistance would be increased in all other cases, right? If we look to the option C and option C, why not those? Heart failure and MI, those will lead to cardiogenic shock, right? Now, due to that, what will happen? The fluid will be retained inside the uh, if let's say if it is if it is left side heart failure, right? So the fluid will not move from the left ventricle to the system, right? So due to which the cardiac, as we know that in heart failure the cardiac output would be decreased. As I mentioned, in all other cases the cardiac output would be decreased. So here the cardiac output would be decreased, due to which there will be fluid retention in the um, left ventricle, right? That fluid will go in the backward direction in the left atrium. So the pulmonary capillary wedge pressure would be increased. Now the fluid will go, if let's say if that is right heart failure, the fluid will go in the will accumulated in the right ventricle, then in the left sorry then in the right atrium. So the central venous pressure would be raised, right? Let me draw this for you so that it could be easy. Okay, let's say if it is okay if it is left heart failure. Okay, so over here the fluid will be accumulated, then over here the fluid will be accumulated, right? So the pulmonary capillary wedge pressure would be increased, right? Okay, also if there is right heart failure, here the fluid will be accumulated, then this will go in the backward direction, right? So over here the pressure would be increased, so the central venous pressure would be raised, right? Okay, so okay, in cardiogenic shock, high pulmonary capillary wedge pressure and the central venous pressure, low cardiac output, due to which there will be a compensatory increase in the systemic vascular resistance. This is important in all other cases. You know, these all are the opposite of the first one, distributive shock, right? The same is for MI. MI will lead to heart failure, right? That will lead to high pulmonary capillary wedge pressure and central venous pressure with low cardiac output, right? With compensatory increase in SVR. Okay. In like here, hypothermia, they have mentioned the temperature of 35 degrees centigrade, right? Hypothermia can cause uh, distributive shock, right? But the temperature would be less than 32 degrees centigrade, right? But over here they have mentioned that the temperature is 35, so this will not cause that shock, right? Distributive shock. Okay, so as I mentioned, severe hypothermia, that r r hypothermia, that would cause septic shock, which is a type of distributive shock. Okay, but not a normal hypothermia like low hypothermia. Okay, pulmonary embolism, that would cause obstructive shock, right? Now what will happen? Okay, there will be low pulmonary capillary wedge pressure. Why? Because if, let's say, if this is the heart, right? If the problem is in the lungs, my drawing is very very bad. Okay, so if, let's say, if there is obstruction in the lungs, so the material, the blood flow, the volume will not go, will go to the left atrium very slowly, right? Okay, due to which, the pressure in the uh, left atrium, that is called pulmonary capillary wedge pressure, that would be decreased, right? But is over here in the lungs there is obstruction, so the fluid, just like in heart failure, the fluid will be accumulated in the left, in the right ventricle, that will move in the backward direction, so that will move toward the right atrium, so due to which we would say that the central venous pressure would be raised, right? Central venous pressure would be raised. Good. Okay, so low pulmonary capillary wedge pressure, low cardiac output, compensatory increase in SVR, as I talked about. In all those other cases, there will be decrease in cardiac output and there will be a compensatory increase in SVR. And I also talked about why CVP, central venous pressure, would be increased, because blood bakes up in the capacitance veins, so increase central venous pressure, right? Okay, I talked about all these things. What happened to central venous pressure in hypovolemic shock, right? That would be decreased. In cardiogenic shock, that would be increased. In obstructive shock, that would be increased, we talked now. But in distributive shock, the central venous pressure would be decreased. Okay, if we talked about pulmonary capillary wedge pressure, that would be decreased in hypovolemic shock, right? And would be increased in cardiogenic shock. In cardiogenic shock, both are increased, pulmonary capillary pressure, wedge pressure, and with that, central venous pressure, right? And that would be, pulmonary capillary wedge pressure would be decreased in obstructive shock, right? We talked about this. Okay, but the central venous pressure was raised, right? Okay, and pulmonary capillary wedge pressure is also decreased in distributive shock. So central venous pressure and pulmonary capillary wedge pressure both are decreased in distributive shock, while both are increased in cardiogenic shock, right? This is important. And in hypovolemic shock, both are also decreased, right? Okay. What happened to the cardiac output? That is only increased in case of distributive shock, right? This is important. I have mentioned this. This is only increased in distributive shock, while in other decreases, right? SVR is a compensatory mechanism, would be increased in all with the exception of what? Distributive shock. Because the primary mechanism of distributive shock is vasodilation that would lead to decrease in SVR. And this is also important. The maxed venous oxygen saturation, that is only increased in distributive shock. Why? Because the cardiac output would be high, right? While in other is the cardiac output is decreased, so that would also be low. Okay. In tamponade, they're talking about this point, single star. Why the pulmonary capillary wedge pressure is high in tamponade, which is in obstructive shock, right? While in other it is decreased. So they have mentioned the reason. In tamponade, left sided preload is decreased. Okay, but measured pulmonary capillary wedge pressure is paradoxically increased due to external compression by pericardial fluid, right? Okay, so what about this point over here? Over here, they have mentioned that the cardiac index or cardiac output that is increased, and with that saturation, right? So cardiac index and mixed venous oxygen saturation are usually decreased in neurogenic shock due to impaired sympathetic reflexes. This is important, right? What will happen? Cardiac index and mixed venous oxygen saturation that are usually decreased in neurogenic shock due to impaired sympathetic reflexes. This is important. But over here, if we were to distribute a shock, right? In this case, that would be increased, right? But specifically, if you're talking about neurogenic shock, in that case, these would be decreased, right? Okay. So hypertension and evidence of end organ dysfunction, for example, confusion, is in shock. Okay, where there is inadequate oxygen delivery to the organs and tissues of the body. Okay, rapidly multi-organ failure and death can occur. Prompt diagnosis and treatment are essential. Pulmonary arterial catheterization can help determine the type of shock to help guide treatment. Low systemic vascular resistance with peripheral vasodilation, distributive shock. I talked about this thing. Septic shock usually due to bacterial infection. Most common type of distributive shock. Central venous pressure, right-sided pressure, right-sided preload, decreases, decreased in septic shock, right? They're talking about right atrial pressure due to widespread vasodilation. In response to systemic release of pro-inflammatory mediators, pulmonary capillary wedge pressure, that is the left atrial pressure, left-sided preload, decreased as well due to reduced venous return. We talked about this. Compensatory increase in sympathetic drive, increases cardiac contractility, heart rate, increased cardiac output. Okay, the high rate of blood flow through the systemic capillaries prevents complete extraction of oxygen by the tissues. This thing is important. High rate of blood flow through the systemic capillaries prevents complete extraction of oxygen by the tissues, resulting in high mixed venous oxygen saturation. Okay, this is important. So why not option B? GI bleeding can lead to hemorrhagic, that is hypovolumic shock, characterized by low central venous pressure, pulmonary capillary wedge pressure, and cardiac output. So compensatory increase in SVR. MI, that is, can lead to heart failure. I talked about this. That would lead to cardiogenic shock, high pulmonary capillary wedge pressure and central venous pressure. Cardiac output decreases, compensatory increase in SVR. We talked about this. Moderate to severe hypothermia. We talked about this. Hypotension due to bradycardia. Okay, but mild hypothermia doesn't typically lead to shock. We talked about this. Septic shock can present with either hyper or hypothermia. Hypothermia presentation, cytokine-induced dysregulation of temperature control in the hypothalamus and associated with poorer outcomes. Okay. Acute pulmonary embolism, obstructive shock. We talked about this. Blood flow to the pulmonary circulation impeded, reduced left-sided prelude, low pulmonary capillary wedge pressure. Okay. So, but high CVP. Okay, this is important. So reduced cardiac output with a compensatory increase in SVR. Okay, we talked about this. So septic shock present with either hyper or hypothermia. Initial disturbance is peripheral vasodilation, decreased systemic vascular resistance, so decreased central venous pressure, decreased pulmonary capillary wedge pressure. Compensatory increase in sympathetic drive causes increase in cardiac output, so resulting in high flow rates, lead to incomplete oxygen extraction in the tissues, resulting in high mixed venous oxygen saturation. Right? So once again, septic shock, primary disturbance, peripheral vasodilation. Right? So CVP and pulmonary capillary wedge pressure decrease, cardiac output would be increased, and SVR would be decreased. SVR is already decreased, initially, because that is the primary disturbance, due to which the cardiac output is a compensatory mechanism would be increased. Right? Hypovolemic shock, right? Volume is low, so less venous return, so less CVP, decreased CVP, decreased pulmonary capillary wedge pressure, so decreased cardiac output. Because uh, as we know, cardiac output is stroke volume multiplied by heart rate, and we know that stroke volume is uh, directly related to venous return, right? Since depends on the preload. So if the venous return is low or decrease, that will lead to low preload, that will lead to low stroke volume, and that will lead to low cardiac output. Is a compensatory mechanism, SVR will be engaged. Okay. Similarly, cardiogenic shock, cardiac output is low, will lead to increased CVP and pulmonary capillary wedge pressure. So increase SVR is a compensatory mechanism. Why? Why capillary central venous pressure and pulmonary capillary wedge pressure are increased? Since the fluid is not going out from the left ventricle, so the fluid will be accumulated, right? That will move in the backward direction to the left area, right? So pulmonary capillary wedge pressure. Similarly to the right area, that will lead to central venous pressure rise. Okay. Similarly, obstructive shock, since there will be obstruction from the lungs toward the left side of the heart, right? So there is obstruction, so the left atrial pressure would decrease, right? But since there is obstruction over here, okay, so the fluid will be accumulated in the right ventricle, then to the left ventricle, sorry, right ventricle, then to the right atria. Okay, so due to which the central venous pressure would be considered is raised. Okay, and due to which the cardiac output would be decreased. As a compensatory mechanism, SVR would be raised. Right? Thank you. So we will continue then from question number 12. Thank you.